What are the most important things that people want to hear addressed in this meeting? The thing that consistently came back was about workforce. Don't tell us all about all these fantastic ideas and these fantastic plans. If we don't have the people to deliver them, then it's all very interesting, but actually it's just a plan and not going to work. So workforce was one of the many things that came forward as an important topic for discussion today. So I'm delighted to introduce our speakers. I'm not absolutely sure who's got the first gig. It's you. Well done, Claire. Come on.
Thank you. Right. So thank you very much, Ruth. And in terms of starting off, we did actually say, is it a good thing having the last slot on the day? But actually there's masses of energy in the room, and all of you have come back in, which is a good sign. And I've been told that I need to keep this session quite energised. I think really importantly, what we're going to look at, which is slightly different to what I've been hearing all day, and it's been a great day. There's been a lot of focus and attention on the what throughout the day. We're going to actually start to think a little bit this evening about how. So some of the learning from some of the sites, from new care models, from the primary care home sites, and actually drawing from that some ways in which you might develop and transform the workforce. I've forgotten to introduce myself. So I'm Clare Simpson. I am the National Workforce Lead for the National Association of Primary Care and the Primary Care Home Model. And I've also been working with NHS England New Care Models for the last 18 months. And the learning we've got draws from all of the new care models across England. So in terms of what we're going to cover, we've got 3 things and 3 speakers, so that's perfect. The first bit we're going to look at is actually how you design a workforce around population health. So that's the whole essence of what we're trying to deliver here. Then I'm going to talk through, and Steve's going to take us through that, in terms of what we're learning from the sites and how we have tried to distill that learning to make it translatable, accessible, and possible for other people to adapt for their own systems. I'll talk through what we've done around that. And then really importantly, Maria will then talk about how we put it into practice. So looking at Thanet and what they've actually done in terms of creating multidisciplinary teams and integrated workforce.
Hello, everybody. So I'm the thorn between 2 roses here. I'm Steve Laitner. I'm a practicing GP in Hertfordshire and also clinical advisor to Carnall on the STP. So a brief introduction to primary care home. And a primary care home, it's about the health of a whole population in a locality. It's about a locality of around 30 to 50,000 because we think that makes sense both to the local community and to the teams of people that work within that locality. It's about the whole health of that population, and it's about the multidisciplinary team and aligning financial drivers. Back to roses, it doesn't really matter what we call these things, whether we call them a chocolate, a locality, a neighbourhood. It's about what it does, which is bringing teams of people together to improve the health and well-being of a local community. So where do you start with that? What's the lens that we look through? And the best quote I've seen is from the late Steve Jobs, who found when he was building technology in his father's garage in California that wasn't the place to start. The place to start with, what does the customer want? What does the patient want and their family? And actually Steve Jobs went a stage further and he predicted what people would want as a user of technology before they knew it. So when the iPad came out, everybody said, oh, well, that's just a jumped up iPhone. Nobody's going to use that, and how wrong the focus groups were. When I, after years of trying, brought around telephone triage access in my GP practices, a lot of the GPs didn't think it was a good idea. A lot of the patients thought all they wanted was an appointment with their GP. But actually, when you introduce the model, both clinicians and patients alike found actually having a conversation with a clinician was absolutely what they wanted, even if they didn't realise that at the beginning. Unfortunately, the NHS often suffers with the wrong end of the telescope perspective, and it starts with the service, with the disease rather than the person. Obviously, that's not the case with this STP, as we've heard today, but that is a tendency that we tend to gravitate to the wrong end of the telescope. So when it comes to population health management and segmentation, whilst risk is part of it, and clearly people will have conditions and they'll be in receipt of services, that's not the place to start. Don't start with the disease or the service, start with the whole person. So people are not asthmatics or diabetics. We're not defined by the conditions that we have. We are a person who happens to have a disability or a disease or a condition or a need. And that's why we've built with the National Association of Primary Care, building on the work of the KID and Carnall Farrow work on that, the 3x3 matrix, which is basically saying people have 3 big life courses, children and young people up to about 25, working age adults, and then older people. And as you've heard, the work that headed up by Caroline and local care is we've focused on the working age adults and older people with complex needs, because actually that drives about 45% of the occupied bed days, and those are the people who really need coordinated, integrated, holistic care by lots of different disciplines and agencies working together. Because often the NHS can have quite an unnuanced approach to need. It either says everybody needs continuity of care or nobody does. Actually, it's quite different to that. And just my final slide. This is an example of one of our primary care homes in Lewis. And what they've done, and they've looked at a dimension of this matrix just around acute care, and said actually in relation to acute care, there's quite a lot of the population who are generally well, who have well-managed long-term conditions, who actually just want a conversation with a professional quickly and they want a response. They don't need a high degree of continuity, but actually they want a rapid service and their acute problem sorted out. There's then a group in the population who do have long-term conditions, who actually ideally would like to speak to a clinician they know and who knows them and their condition. And then the team that the group in the society that we've focused on in local care is the group at the far end, be that children, young people or adults, who actually have really complex needs and who absolutely need continuity of care, but need a multidisciplinary team wrapped around them and need highly proactive as well as responsive care. So we're here to talk about workforce, but the workforce starts with the need, and back to Claire to talk about how that comes about in action.
Thanks, Steve. So I think Steve's really positioned that well, so you can start to see how we're looking at the workforce in relation to what it is that we actually need them to deliver. One of the things that we have noticed, and I'm sure many of you sitting around the room, is that we have had for a long time a very significant focus on roles and supply. And we look at organisations, we look at professions, we look at roles, and we don't actually think necessarily as strongly and in as focused a way on our existing workforce. So what we're saying is we need to shift the balance from supply. It's not saying that we don't need more, but that we need to do far more with what we've already got and how we can actually connect the workforce that we've got around us. And that actually means about looking way beyond the traditional boundaries that we currently look at when we think about workforce. I've heard it actually in some of the sessions that I've sat in on around the patient being part of our workforce, and actually thinking about social care, health care, people in the local community, whether they're carers or volunteers, and actually starting to think, how can we get far more out of the people that we have working with us? I know that we've probably got loads of examples of where we have different parts of the local systems actually delivering the same thing. So delivering the flu jab, there could be 3 different organisations that are responsible for it. This is about integration and actually working out how to do things better. Really importantly as well, we talk about the quadruple aim. I'm sure everybody is aware of the triple aim. And Sika et al. Came up, looked at and were able to evidence that actually you can only really deliver the triple aim if you have an engaged and motivated workforce. So we have to focus on getting more out of the people that are currently with us, getting them to do the jobs that they're actually joined to do and do the things that they really get value and meaning from. In terms of, so we're saying, let's stop thinking about roles and supply. Let's start thinking much more about what's the need we're trying to address. Steve's already talked about this very clearly. We've used the same example in terms of frail elderly to work out what are some of the functions then that we might need to be able to deliver. And what does that mean for us in terms of the capability that we need and the capacity that we need in terms of the workforce to deliver it? And how can we make that work well in practice? One of the most important things that we have discovered, and I've heard again in many of the discussions, involve the people who are actually doing the job, because they know far more what the challenges and the issues are, and will come up with the ways of reconfiguring and doing it differently, and talk to you very coherently about a new approach and how they can join things up in a different way. So, from roles to functions to teams. So the final part is, how do you actually bring together and making sure that you are getting people to connect in a very different way. And I think it is important to say that this is not a traditional sense of team. So we like to talk about this as squads, hence the picture. And I thought it just, kids are always, more pleasurable on the eye looking up there. And it's about the football analogy of a squad where you actually have a group of people together, and then you find the right players to go and do the right thing at the time you need to go and do them. It's a very different way of working. It's more about networking. It's bringing groups of people across different organisational and professional boundaries and helping them to work together in a very different way. What's really important to recognise in this is that that means that we're talking about human beings as opposed to organisations. And we all know that human beings are predictable in their unpredictableness. And so what's very important is we need to find what's the common thread, what will actually draw these people together and keep them working well around the thing that they all have a common belief around. And this It is, everyone joins the health and care in order to provide great outcomes, great experiences for the patients. And that's the biggest value that you can connect this team to. So it's where you get the opportunity to really get them focusing on the things that they've joined to do. The other really important thing about this is I think people get very anxious about creating a rather generic workforce. So everybody losing their specialism and actually focusing on doing everything, but not perhaps actually really focusing on the things that they can do very well. So the really important thing about bringing these teams together is that you don't do that. You actually focus on keeping that creative tension going, valuing the differences, allowing people to share their learning and experiences and to build their capability and knowledge through education networks, bringing people together to learn from their mistakes, to learn from each other, to learn how things can be done. And leadership that allows them to innovate, take decisions and and do things in a different way. The other thing that we talk about is actually keeping this small enough that people can actually get to understand and know each other well enough, both their population, as Steve has already talked about, but also in terms of their team. So they have a sense of belonging and sharing and can actually trust each other. So I was in one of the workshops where we were talking about whether or not you needed structures. Would there just be one employer in the future? And potentially there will be, but actually for the time being there's going to be lots. And we need, therefore, for people to be able to trust and work across those boundaries, knowing that there will be different ways of doing things. So it's all very well talking about, so I'm talking about some of the learning that we've got from the sites, and I said that we have tried to distill this into 3 key areas, which Maria will talk through in practical terms as to how she's used this to work through building teams, multidisciplinary team working in Thanet. So we've got 3 defined areas that we have identified. One is about designing the workforce around population health. So this is about workforce modelling and workforce planning. And within this, we have identified tools that can be used to help to validate designs. But actually the most important thing is getting people to talk through and work around what are the issues that they've got and how do they come up with the better way of making it work in practice. The other big element around this, and by the way, this is not a linear process, these things happen together, the leading change element, so the type of leaders that you need to do this in terms of collaborating and working across the system. I've heard a lot about shared vision and shared ownership. And actually the whole involvement and engagement of the workforce to make these things happen. And the final bit is about making it work in practice, so developing the effective multidisciplinary teams and using education networks to share the learning. I'm going to pass to Maria to talk about it in practice.
Thank you. So in the 4.5 minutes, thank you, yeah, that I've got. So how did we put this into practical practice? So in Thanet, we'd previously been looking at our over 75 population, but our clinicians felt that, actually they'd done a great piece of work on that. For Thanet, you can be 50 and frail at that age. So we actually started looking at the over 60s. Using the frailty index tools that are already embedded within EMIS, and all our practices are fortunately on EMIS, they were able to identify those that were mild, moderate or severely frail. Because what we're trying to do is have a scheme, if you like, or a pathway that looks at how we build community resilience, what's the patient activation levels around self-care, self-management, right through to those that need some more acute type care, with maybe services being provided to patients or persons that live in Thanet in their own home for up to 7 days. And of course, before embarking on this piece of work, we didn't actually know what the size of the problem was. So there was already teams that existed, and the irony of it, I guess, was that they were called an integrated discharge team, an integrated community team, but none of them were integrated. So once we'd sort of established what was already out there, so Claire's point about, what already exists, we were able to identify the gaps and how we could then work differently. I think one of the key things for us in Thanet is that it's been organically grown. The clinicians, frontline staff, the patients have very much shaped how this looks. So we've done the estimate, we've listened and continually listened to what our patients are saying around what are their needs. And the staff have been able to lead that change as well. And if you talk to particularly some of our community nursing colleagues now that are part of a nursing team focused on competencies rather than, numbers of staff that we've got, for them, how they work and how they feel about their roles is significantly changed. And one, often sort of says about it's brought the joy back into her work. She feels valued as part of a team. And, I don't think you can get much better than that in actually terms of retaining the workforce and continuing to grow it. I think back to probably about a year ago, sitting in meetings, because all the staff are still employed by their relevant organisations, none of that has changed. Trying to agree a set of terms of reference for actually how we were going to conduct our meeting. We had to quickly bin that because we weren't getting anywhere. And if we'd stuck to that rigid governance process, not saying it's not important, it clearly is, it needs to be safe what we're doing, but it can't be a blocker to trying to achieve some of the things that we're trying to do. And it is very much a sense of that we're all in this together. So just working through the final stage of it, we'd identified that population segment, the over 60s I mentioned. We'd listened and looked at what the patient needs were around that population. We put the scheme in place. I'm not saying we've got it right. It's constantly being reviewed on a 6-monthly period. And we're just about from tomorrow entering into a third phase of a 6-month review. We've done it within all the existing resources, all the existing staff, apart from the addition of a GP and the money associated with that going into the acute response team. So that wraparound package. We've used existing money that's in the system, so no new investment in that. We continue to engage all our stakeholders I've already mentioned, and what we're trying to do now is to maintain whatever that scheme ends up looking like in its evolved state. How do we then build on the workforce? We've got a lot of people that will retire in the next 3 to 5 years, so we need to think about how we're going to fill those gaps and then commission the appropriate education and training around that. But we're really trying to push the boundaries. So, colleagues that work for some of the other arm's length bodies, professional regulations, are really supportive of what we're trying to do and work with that. So I think, together we are able to achieve great things. and I'm only 16 seconds over. Woohoo!